Welcome everyone to the fourth and final segment of our first QA forum of 2021. My name is Dr. Michael Novick. I am the Director of Education and Associate Director of Quality Assurance for vRad. In this section, we'll be talking about zebras or some unusual cases that we don't typically see in our day-to-day practice. Feel free to review our accreditation statement at your leisure, as well as the learning objectives for this lecture. Our first patient is a 27-year-old woman with abdominal pain. Let's begin with the axial images from a contrast-enhanced CT scan of the abdomen and pelvis. I trust that you are all employing your search pattern here as we scroll through the upper abdomen. And we'll take a look at the sagittal images, which provide a nice view of the pertinent findings. All of the findings are visible on this axial image. It's fairly subtle, but the enhancement pattern of the left kidney suggests mild venous congestion. And there is marked focal narrowing of the left renal vein as it passes between the aorta and superior mesenteric artery. On the coronal images, we can appreciate some collateralization as a result. You can usually make this diagnosis with the naked eye, but there are some measurements that are also useful. One is the left renal vein hilar to aortomesenteric ratio. You simply compare the diameter of the renal vein at the level of the hilum to the diameter at the level of the aorta. In this case, that number is 5.4. Another useful diagnostic tool is the aortomesenteric angle. You obtain that by measuring the angle between the aorta and the superior mesenteric artery in the sagittal plane. In this case, that angle is 18 degrees. And this constellation of findings is consistent with Nutcracker syndrome. Nutcracker syndrome occurs when the left renal vein is compressed between the aorta and the superior mesenteric artery, not to be confused with SMA syndrome, which involves obstruction at the level of the duodenum due to similar circumstances. Of course, this is radiology, so everything has a sign. The beak sign is the appearance of the left renal vein being compressed, and you're looking for a left renal vein hilar to aortomesenteric ratio of greater than 4.9 and an aortomesenteric angle of less than 41 degrees, both of which were present in this case. If you're interested, AJR has a very interesting article on Nutcracker syndrome and other abdominal vascular compression syndromes. Our next case is a 7-year-old boy with thrombocytopenia and concern for leukemia. These are the axial images from a contrast-enhanced CT scan of the abdomen and pelvis. This too is not an eye test. There are obvious abnormalities in the liver. There are some other findings here, some mild bowel wall thickening, a little bit of ascites, some lymphadenopathy. And I'm sure you saw the findings at the lung bases, but focus on the liver here. And scrolling through the coronal images from the same examination, the findings in the liver are not subtle. We have multiple complex cystic lesions in the liver, and if you scroll through carefully, you'll see that they are all interconnected and associated with the biliary tree. This is an Ant Mini multifocal cystic biliary ductal dilatation. is associated with Caroli disease. Caroli disease falls under the spectrum of choledochal cysts. It's a type 5 choledochal cyst. It's autosomal recessive and carries an increased risk of cholangiocarcinoma. For that reason and others, unfortunately for this little boy, it also carries a poor prognosis. This article from AJR provides a nice review of the imaging features of Caroli disease. Our next patient is a 17-year-old boy with pain. We begin as we should with an AP radiograph. And let's scroll through the axial T1 weighted images of this boy's knee. On the axial fluid sensitive sequences, we can see a joint effusion and a large mass in the lateral tibial plateau with associated bone marrow edema. We were fortunate enough to have post-contrast sequences for this exam. Note the brisk intralesional and perilesional enhancement. And as we scroll through the coronal images, you can clearly see that the mass abuts the articular surface, which should provide you with a very strong hint as to what this entity is. Returning to our plain radiograph, I think you can all see the large lucent lesion in the lateral tibial plateau. And as we saw on the coronal MRI sequence, the lesion abuts the articular surface. This axial T1 weighted image demonstrates the lesion very nicely. It is iso-intense to mildly hyperintense relative to muscle. And you can see there is a narrow zone of transition which suggests a non-aggressive lesion. On this axial fluid sensitive image, we can see pronounced adjacent bone marrow edema. And on this axial post-contrast image, we can see brisk intralesional and perilesional enhancement. This is, of course, a giant cell tumor. These lesions are susceptible to pathologic fracture, and you can see on this follow-up plane radiograph there is a cortical step-off at the level of the articular surface consistent with pathologic fracture. We may not encounter these lesions as often as some of the other bread-and-butter emergency radiology cases, but we're all familiar with the findings from residency. The physis must be closed, the lesions abut the articular surface in almost all cases. They are well circumscribed with a narrow zone of transition, and they are eccentrically located. Here's another reading recommendation for you for your leisure time, courtesy of Radiographics. This is an interesting case I came upon in my travels, so I thought I would share it with you now. This is a 55-year-old man with abdominal pain. A CT scan of the chest, abdomen, and pelvis was obtained, and as we scroll through the chest portion of the examination, we see loculated complex fluid in the mediastinum, extending through the hiatus into the upper abdomen, where there is fairly extensive inflammatory change and loculated fluid. The coronal images do a really nice job of demonstrating how confluent the fluid is between the upper abdomen and the mediastinum. Quite a lot of inflammation in the upper abdomen as well. Again, we have complex multiloculated cystic lesions in the mediastinum. This sagittal image demonstrates how confluent the fluid is in the mediastinum. And in the upper abdomen, there is evidence of acute pancreatitis with pseudocyst formation. I thought this was pretty neat and not something you see every day. This is intrathoracic extension of pancreatic pseudocysts. Our last patient is a 10-month-old boy with a history of medulloblastoma presenting with septic shock. We'll begin with axial images from a contrast-enhanced CT scan of the abdomen and pelvis. I'll scroll fairly quickly through these images, as the findings should be readily apparent. The corresponding coronal images from the same study. There is a VP shunt catheter in the abdomen. There is a large amount of ascites. There's mass effect on the abdominal organs and GI tract. So let's review our findings. Here is our VP shunt catheter partially visualized on this axial image. There is a large amount of loculated, mildly complex ascites. The hepatic surface is scalloped. And the bowel loops are centrally displaced. The findings are even more conspicuous on this coronal image from the same study. We can again see the VP shunt catheter, the large amount of loculated complex ascites, the somewhat scalloped hepatic contour, and the central clumping of the bowel loops. The diagnosis in this case is a peritoneal CSF pseudocyst, which is an uncommon complication of VP shunt catheters. This case demonstrates the typical appearance with a loculated cystic mass associated with the VP shunt catheter tip and mass effect on the adjacent organs as we saw. In more chronic cases, there can be internal septations, and with infection, you can begin to see internal echoes and debris. This is an ultrasound image from the same patient demonstrating a large amount of internal debris and septations and complexity, which is consistent with superimposed infection and is the reason why our young patient presented with sepsis. With that, I thank you all for your time and attention, and I look forward to seeing you next time for our second quarterly QA forum. Thanks again.